The Alcyone trial, which was recently published in the New England Journal of Medicine, of dara, bortezomib, melphalan, and prednisone, DVMP, compared to VMP alone, showed a significantly higher response rate, significantly higher progression-free survival for the dara VMP arm, and a favorable toxicity profile. Its implications in the United States are probably very different than its implications in the rest of the world, because the use of VMP in the United States is so low, and I don't think that this trial is going to change that, and that we're going to suddenly switch from RVD, even in our elderly transplant ineligible, to suddenly using dara VMP. But it will just allow us to say that you can give 4 drugs in an elderly population in the frontline setting, and it can be tolerated. You know, without going into the weeds of the study design, you know, that study is not a perfect study design in regards to the experimental arm and the control arm. The control arm, you know, received a set number of courses of therapy, because that again speaks to the way that you can give VMP. You can't give it indefinitely until disease progression, compared to daratumumab. But my other takeaway from that trial is the fact that in the dara VMP arm, patients continued on daratumumab and have been able to be maintained on daratumumab for long periods of time, suggesting that it's a very attractive agent as a maintenance strategy, a once-a-month infusion, and as we see daratumumab ultimately become a subcutaneous drug, even more attractive as a long-term maintenance strategy in a transplant ineligible population. The MAIA study of daratumumab plus lenalidomide and dex in comparison to lenalidomide and dexamethasone is an important study. I think it will very likely show that the dara RD arm is going to be superior in terms of PFS and in terms of MRD negative rates. We've already seen that in the relapse setting with dara RD versus RD alone. I think it will allow us, for older patients who are not going to transplant, another option in the frontline setting that will be more commonly adopted in the United States, because clearly we use a lot of our upfront as our induction regimen. Daratumumab plus carfilzomib and dexamethasone was presented at ASCO this year, and it showed us a couple things. First, they used the carfilzomib on a weekly dosing schedule, escalated up to 70 milligrams per meter squared. The daratumumab, after initial safety run-in, they split the dosing over 2 days, which is a question we tend to get a lot because of the first length of the first dose of dara. So it was a nice trial because it addressed some of the concerns of giving 2 IV drugs, and it showed that split dosing was very feasible. It showed that the combination of dara plus weekly carfilzomib had no new safety signals. The cardiac toxicity grade 3 was 6%, which was very much in keeping with our prior carfilzomib experience. So that was very encouraging. And the response rates were very high. The response rates were about 90% in lenalidomide exposed patients, and a little in the high 80s for patients who were lenalidomide refractory. Now, having said that, one important point to keep in mind about that dara carfilzomib dex trial was those patients were carfilzomib naive. Nonetheless, it suggests that in patients who had other proteasomics inhibitor exposure and who were len refractory, for example, this is a good alternative regimen to consider.